Assalamu alaikum and good afternoon everyone, and thanks for the introduction, and thanks for the SSBMT for bringing us all here to hear some updates about lymphoma, which will be reflected on the patient care that we provide. So today I'm going to present the updated or the final results from this ZUMA 7 trial, which was updated in the most recent Lugano meeting. So all of us, we treat diffuse large B-cell lymphoma, and we know the upfront treatment is R-CHOP, but unfortunately not everyone goes into remission. Almost about 2/3 of the patients, they go into remission, but always the challenge in that 1/3 who do not go into remission, what to do with them. So now with the current practice, the standard of care is salvage therapy followed by autologous stem cell transplant, but the problem that lots of patients, they are not eligible for that because of age or comorbidities, or they do not respond to salvage therapy. So practically only minority of those patients who are refractory, they go into transplant. And we know that that group of patients, they do poorly based on the ORCARD trial, which showed that the survival for that group of patients who are refractory is about 10 months. So the AXICABTAGENE is a CAR T-cell, autologous CAR T-cell targeting CD19. It was initially developed and approved for patients with relapsed DLBCL after 2 lines of therapy. So the ZUMA 7, we're trying to use that for that difficult to treat group of patients who are either refractory to the first line of therapy or they relapse within the 12 months of R-CHOP. So the inclusion criteria were DLBCL, either refractory or early relapse within 12 months. They were randomized based on either refractory or relapse, and also using the age-adjusted IPI. Patients were randomized to receive either AXICABTAGENE or the standards of care, which is salvage therapy followed by autologous stem cell transplant. The primary endpoint of this trial was EFS. Secondary endpoint, which I'm going to present for this meeting, is the overall survival. So we can see here that the groups are well balanced between AXICABTAGENE or standard of care. About 3/4 of the patients were primary refractory, and significant number of patients were above 65. So we're talking about a difficult to treat group of patients. So 180 on the AXICABTAGENE arm, 179 in the standard of care arm. And you need to notice that most of the patients on the AXICABTAGENE arm, they reach to receive their intended treatment, which is the AXICABTAGENE. But about only 1/3 of the standard arm patient, they underwent transplant, and that was mainly related to failure to respond to salvage therapy. Another point you need to remember that for the standard of care arm, they were allowed to go for further therapy if they could not go for transplant, meaning they are allowed to go for another cellular therapy like bispecific or another CAR T-cell of different product. So as I mentioned to you, the primary analysis was ended in the first quarter of 2021, and the results of the EFS was presented and also even published in the New England Journal of Medicine. And maybe you are aware that the study met its primary endpoint with improvement of the EFS and the AXICABTAGENE arm in comparison to the standard of care, with you can see the EFS of 8.3 versus 2 months, with a hazard ratio of 0.39, the relative risk of almost 60%. So what was updated recently is the final analysis showing the survival data, and which is not something uncommonly to see in the second-line therapy for DLBCL, survival advantage. So actually, this trial showed survival advantage with AXICABTAGENE in comparison to the standard of care. And we can see here in the AXICABTAGENE arm, the median overall survival was not reached, but it was only 31 months in the standard of care arm. And we can see here the difference at 4-year interval, 54 versus 46 months between the two arms. And you need to remember that happened despite using other cellular therapy like bispecific or other CAR T-cell products, meaning that the other philosophy of using chemotherapy up front and saving the CAR T-cell for later might not be the way to go in these group of patients. So the study was not powered to show the subgroup analysis difference, but despite that, we can see the trend of improvement of the benefit among all the subgroups. So also the PFS, there was a significant difference in terms of the PFS between the two groups, the AXICABTAGENE 14.7 months versus 3.7 months. And you can see here this very nice plateau curve, meaning that these patients are really cured. And we love to see that curve in PFS data. We can see at 4 years, the people who received AXICABTAGENE, they maintained their PFS. So 41 versus 24%, meaning almost a 16% difference between the two arms. So in terms of the safety data, as we expect, there will be a CRS. We are using a CAR T cell. So many patients they had a CRS of any grade. Only minority, there were 3 or higher. Also, the hypogammaglobulinemia, it's a common problem with CAR T cell, and that's why it's recommended to give IVIG as needed. The infection rate was comparable between the two arms, and in terms of the deaths, it was mainly related to progressive disease. So why all of this? So if we want to analyze the product itself, we see that after the infusion of the CAR T cell, there will be that period of expansion, which happens immediately after the infusion. But after a few months, the CAR T cells started to go down. And by about 1.5 years, there will be no circulating CAR T cell in most of the patients. But despite that, as you look at between 6 to 12 months, there was a significant drop. But despite that, that was not associated with increase in the progression during that period of time, which means that most likely the disease was eradicated before the CAR T cell vanished. So what are the factors that might affect the product is the amount of the naive T cells. The higher amount of naive T cells would show an improvement of the PFS, and also less amount of memory T cell. What does that mean? Using CAR T cell earlier would give you a better product than keeping it later after exhausting multiple lines of therapy. So, in conclusion, the AXICABTAGENE improved the survival as a second-line therapy for patients who are primary refractory or early relapse, a 27% reduction in the risk of death. This is something we not commonly see in that group of patients, and that actually would result in changing the paradigm of treatment of early relapse primary refractory DLBCL. So ZUMA-7 confirmed AXICABTAGENE is a second-line standard of care for patients with refractory early relapsed large B-cell lymphoma based on superior survival. Now, so now I think the paradigm of DLBCL primary refractory has changed, and I think if we have a patient who is relapsed DLBCL, I think instead of asking ourselves, is the patient transplant eligible or not, I think the most important question is, when did the relapse happen? Is it within 12 months or no? Because if it is within 12 months, I think we should consider CAR T cell higher in that group of patients rather than keeping it till the end. So that's what I have, and I'm happy to take any questions.